Over the years, On Call with the Prairie Doc has investigated many subjects, unique cases, and everyday maladies. There have been a few stories that, while interesting, we were not able to produce for our regular episodes. This is our opportunity to take a look at a few of what we are calling Prairie Doc Insights. Tonight, On Call with the Prairie Doc, celebrating our 20th season. Good evening. I'm Dr. Kelly Evans-Hullinger. Tonight, we continue to celebrate 20 seasons of truthful, tested, and timely medical information brought to you through the On Call with the Prairie Doc program. Each of our 4 Prairie Docs tells us about a medical topic of personal interest to them. First up, Dr. Andrew Ellsworth. Living in our rural communities can make it difficult to deliver medical care over the distances and in the environment we are given. Andrew tells us about a program called Frontier and Rural Medicine, or PHARM, offered at the University of South Dakota Sanford School of Medicine.
Riley, tell me about where you are in the process of your medical education.
You bet. Danny and I are both in our 4th year of medical school. Medical school has 3 parts. There's a bookwork, a general clinicals, and a specialty clinicals. So we did the bookwork, we did our general clinicals as part of the PHARM program, which we're going to be discussing today in various rural communities, and now we are in the specialty clinical portions where we're in the bigger hospitals in the state doing that.
And so you're in your 4th year of medical school.
In our 4th year.
And so next year then you'll go on to residency.
That's
it might
correct.
be 3, 4, 5 years. And this is all after 4 years of college. So you're
Yes.
over halfway there, maybe.
We're getting there.
Getting there. Tell me about the PHARM program, please.
The PHARM program is the Frontier and Rural Medicine program. The University of South Dakota School of Medicine sponsors this program. So each year, 10 or now 11 students are selected out of each class to participate in the rural medicine track throughout South Dakota.
70 students in a class?
Yes,
So
yep. There are 9 different sites throughout the state. So I was placed in Pierce, South Dakota, and Riley was placed in Winter. So throughout our time in the PHARM program, the advantage is that we work with a smaller number of providers. So we know the physicians in the town very well. As a result, we gain their trust and rapport, and we are allowed to participate a little bit more closely in patient care than some of our colleagues are.
how long were you there then?
We were there for 9 months.
Do you feel like you got to know the community?
Definitely. So one of the requirements of the program is a community service project, and so beyond being in the community and wanting to integrate ourselves in the community, it's actually required. So while we were there, we participated in probably a couple of different activities, got involved in some of the local groups, got to know a few of the people who lived in the town outside of the hospital as well.
Yeah.
Riley, what were some of the benefits to the program, do you feel?
Like Danny said, the benefit of the program is being able to work alongside just a smaller group of providers. I think that's the key. And being in the community, of course. I think that we were able to gain the trust of our patients simply because we were seeing them month to month, which for a student in Sioux Falls may not be the case because you're bouncing between clinics so frequently. And as a result of that, we have the privilege to administer medical care to a patient, right? It's not something that we impose ourselves upon a person, but we really are invited into that.
You're part of the team.
Part of the team. And so we were really able to realize that even more than maybe some of our classmates were.
Yeah, how would you compare your experience to some of your classmates?
My schedule was different than a lot of the rest of our classmates. So the people in Sioux Falls or Rapid City or Yankton have a more rigid schedule, and so they're told which hours are going to be in which clinics and what they're going to do and which days they're going to participate in each specialty. In the PHARM program, there was a lot more flexibility, and some of that comes along with having lower patient volumes in those communities. And so if I was scheduled to be on the hospitalist service with the hospitalized patients, but someone was having a baby, I was welcome to leave that service and go and assist in delivering the baby and then return to whatever it was I was doing. Where in the bigger campuses that's not an option because there was someone else that was on the OB service that would have had that privilege to help deliver that baby. And so in Sioux Falls, it's a little bit more rigid. Everyone stays with what they're scheduled to do. Where in the farm program, it was much more flexible. And so we had the opportunity to participate in many more things than some of our colleagues did.
Yeah, I would say that we crossed departments frequently. So you could go from inpatient hospital to the emergency room to labor and delivery, back to the hospital again.
Did you get more continuity of care?
Absolutely.
Yes. So there was a few instances where you might be in the emergency room, a patient comes in needing a surgery, and so you watch the surgery, assist with the surgery oftentimes, actually helping the surgeon, and then follow them throughout their hospitalization, and then at the end, see them in the clinic for follow-up. And so you could see the same patient many times over the course of a month, where for that to happen in Sioux Falls, you have to be in the right place at the right time instead of intentionally making that happen.
That's great. You're getting to see the care of the patient throughout all these different steps.
Mm-hmm.
Danielle, when you are now interviewing for residency programs across the country, is this a program that they're very familiar with in other places in the country?
This seems like a very foreign concept to many of the places where I've interviewed. It is a talking point in nearly every interview. They want to know more about this program, what I learned from the program, what I gained from the program, and how I'm a stronger applicant because of it. And I think that's been demonstrated multiple times throughout the interview season already.
What are some of those strengths, Riley?
Well, just as an example, I was recently in Louisiana. Medical students go and they rotate at the location that they might want to, work at later on in life, okay, or receive their training at, we'll say. So one of the places that I might pursue training is in Louisiana, and I was sitting next to a couple other students from medical schools across the United States, and they asked us how many of a specific procedure, we'll say like suturing or maintaining an airway, okay?
And when you say maintaining an airway, what does that mean?
Yeah, so in this case, I was sitting next to a couple students, and we were asked to indicate how many times we had worked with a patient's airway. And maintaining an airway is sometimes putting in a breathing tube or just assisting with breathing process, performing ventilations.
Which can be very important.
Which is very important. Yep, absolutely. And under the watchful eye, of my physician in winter, I had performed this procedure a number of times. We'll say more than 20 times. Whereas my counterparts going to Tulane or universities in California had only performed this procedure 2 or 3 times.
Wow.
And I think that is directly related to the level of rapport I had with my patients and the level of trust that we had been able to establish with our attending physicians, because I know that Danny had the exact same experience.
Yeah.
Additionally, I think what comes along with that is the confidence in these procedures.
Mm-hmm.
It doesn't matter which procedure it is, whether it's sewing up a cut or putting a breathing tube in someone or helping with surgery. The more you do it, the more confident you're going to be. And so we won't have this period of lack of confidence in the beginning of residency. Hopefully from this, we'll have the confidence to do these procedures from the beginning instead of earning that 6 months into the residency training.
Danielle, this farm program, is it only for students that are interested in primary care or rural care?
The people who are likely to apply for it are the people who are interested in rural care and primary care. But participating in the program does not restrict which specialty you can end up in long term. So even though I participated in the farm program, I'm applying to emergency medicine, which is not always considered a primary care field. I think a large percentage of people who participate in it do end up in primary care, but certainly not all of them.
Sure. And I've heard that there's students that have gone into all the specialties.
Yes.
We have one who participated with us who's going into general surgery this year, and also a few going into family medicine and OB, and you're really not restricted.
Would you feel more comfortable returning to a rural area after going through this program?
Absolutely. And even the general surgeon among our classmates is planning to practice in a rural environment. As you know, in places like Parkston or even in Brookings here, which is a larger town but still maybe considered rural, you certainly have general surgeons taking care of procedures like colonoscopies, gallbladders, appendectomies. And so our classmate Kayla, she's planning on coming back to a small town in South Dakota.
Great. On the interview trail for you, did you happen to have any experiences yet where you really saw, it was an eye-opener where you saw the benefit of the program compared to other places in the country?
I think similar to Riley, that was prior to the interview trail when we were doing our away rotations or external rotations at other places. Again, I was more confident in procedures. I was, instead of asking one of the residents or the physicians to help me find the supplies I needed, I was comfortable finding the supply closet and then getting everything I needed. So comfort in procedures is one thing, and also being comfortable, being trusted by the physicians. That's something that, unfortunately, in the beginning of medical school, you can end up watching a lot, and there's definitely a transition from watching someone practice medicine to practicing medicine yourself. And I think the people who participate in pharm likely already made that transition before residency even starts. And on the interview trail, then we have the opportunity to talk about what that felt like. And I've gotten very good feedback about that feeling.
Mm-hmm. I mean, even the small things like making a phone call to a specialist, right? So someone comes in with chest pain and you have to call the cardiologist. I would say that many of our classmates or folks from other programs across the nation may not be comfortable with that simply as a medical student. But that was something that I did, on a relatively frequent basis as a part of the pharm program. We were constantly contacting our colleagues.
That's great. That's great. Yeah, I think of in many big cities, behind the attending, the main physician, you might have a senior resident and then a intern resident, and the medical students are going to be the bottom of the totem pole for the learning opportunities. And
Yeah.
here you guys are number one doing these great things. Danielle, what made you interested in the pharm program to begin with?
When I started medical school, I was planning on pursuing rural family medicine, and so the pharm program seemed like the perfect track to get me to where I wanted to go. Obviously, over the year, my plans changed, and I ended up liking emergency medicine just as well and even better. So originally,
which we also need in rural places for sure.
So my interest in the pharm program was because I wanted to do rural family medicine from the beginning. And since then, I've found my passion in a different area of the hospital.
She'll be back. I mean, she'll absolutely be in a small town in South Dakota or somewhere in the western United States.
Riley is right. I'm not going to end up in a huge city for the rest of my life.
Riley, what made you interested in the pharm program?
The pharm program was the primary reason I chose to attend the University of South Dakota. And it was because of the opportunity that I would have to get involved with the community, get to know the folks around town, get involved with whether it's a high school athletic team or churches, organizations in town. That's just what I like to do. I like to get to know people and just become part of the family.
Danielle Riley, thanks so much for coming here and doing this interview and helping to spread the word about the pharm program.
You betcha. It's a pleasure.
Thank you so much.
There are many challenges, but by planting the seeds that show the value and reward of a rural medicine practice, programs such as Pharm will continue to grow and provide dedicated doctors for the future. Doctors are people, and of course have a variety of interests that lie outside their normal career. Occasionally, these avocations generate connections that take advantage of their medical skills. Dr. Jill Cruz has flown to great heights due to her passion for aviation.
Well, I wear many hats at the clinic and the hospital, but one of my favorite hats to wear is when I'm an AME, or Aviation Medical Examiner. And what an Aviation Medical Examiner is a physician who does medical exams on behalf of the FAA to make sure a pilot is safe to be a pilot in command of an airplane. So every time before a pilot gets into the plane, they do a very careful pre-check of the plane to make sure that the aircraft is airworthy. My job as an AME is to make sure the pilot is airworthy and nothing bad will happen to them, or no foreseeable medical conditions would incapacitate them or make them where they were unsafe to pilot the plane. As an AME, there are two different classes of it. There's a basic AME and then there's a senior AME. And the senior AMEs are able to do flight physicals for class 1, 2, and 3, where a basic AME can do flight physicals for classes 2 and 3. There are only 4 senior AMEs in the state, and here in Brookings we are lucky to have 2 of those 4. So we do get lots of airmen from really all over the state, and actually I have had international pilots coming in that are coming to South Dakota for flight training that have come to me for their medical certificates. There are 3 different types of medical certificates. The first one is Class 1. Those are for the air transport pilots. So you think of someone who is flying a big plane, multiple engines with multiple passengers. So someone who's flying for United, for Southwest, for a big commercial airliner. The second class is Class 2. Those pilots are the ones that are doing commercial pilots, so spray planes, aerial applicators, aerial firefighters, corporate jets, med flights, so those sort of things where they're getting paid to fly, but it's a smaller plane. And then Class 3 is for your private pilots and to get a student pilot certification. So those are people who are not doing this to get paid, they're just doing it for fun. That would be the class that I would have, because I fly because I love to. I don't fly for money, and I have a great time doing so. So those are the 3 basic classes of flight physicals. Now once you have had one of those, you would qualify to do what is called basic med. And basic med is not a flight physical that's done by an aviation medical examiner, but it's one that's done by your family doctor. And those are physicals that just came out in the last few years for private pilots that don't want to go through an AME since they're so few and they're sometimes hard to find and hard to get in with. If you're just going to be flying in the contiguous US and you're not having a complex airplane, you're just flying a small airplane with your friends, 6 seats or less, then you can do basic med. But you first have to have a class 1, 2, or 3 before you can downgrade to a basic med. And if you're interested in that, do talk about it with your family doctor, because that's who is supposed to be doing it. It's supposed to be someone who knows you and knows your medical history well to make sure that they think that you would be safe to fly an airplane. So with that, there are some doctors that don't feel comfortable with that because of the different things that go into flying an airplane. We think about this when we're at altitude, there's different air pressure, so the air is thinner. So the higher you get, you could exacerbate problems, especially with breathing. So someone who has asthma, someone who has emphysema, someone who has had heart problems in the past, all of those could get worse. So we need to take that into consideration, because little planes like this one are not pressurized like the large commercial jets. Now, I'm definitely not getting anywhere near a United plane when I'm flying in this one, aside from when I'm getting close to land and they're landing. But that is something you have to take into awareness, because if you get too high, the air gets too thin, you can get what's called hypoxia, which is a decreased amount of blood going to the tissues, and that can relate in loss of consciousness. And that's a very bad thing when you're flying an airplane. So we want to make sure that everyone's healthy enough for their heart, for their lungs, to fly in an airplane. And that's where my job as an AME comes in, is to make sure that you are. Because when you're flying an airplane, you can't exactly pull over to the side of the road and get out if you have a problem. If you have a problem, you are in the air and that becomes an in-flight emergency. And if you're the only pilot on board, that's kind of a big deal. So we want to make sure that if there's any in-flight emergencies we can prevent or mitigate the risk for, we want to do that. So there are 10 main disqualifying conditions that the FAA has that says, you know, if you have these conditions, it's probably not a good idea if you fly. And most of them are related to heart issues, are related to seizure disorders, are related to uncontrolled depression or psychosis. So we basically don't want anyone in an airplane that could hurt themselves or hurt others with their flying. Because the last thing we would want to do is to have an in-flight emergency or someone use a plane to intentionally hurt themselves or someone else. So that's where those main 10 conditions come into play. Now, if you have one, say that you had a seizure when you were 5 because you had a really high fever, the FAA is going to look at that and say, we need more information. You know, was it truly only one time when you were 5 and your temperature was 104? That's no big deal. If we can get records from your doctor to, you know, substantiate that, to say you've never had any problems, they will probably say, you know what, we can issue you the certificate and we can get it to you. If you had a seizure 2 weeks ago and you come into me as an AME and say, hey, I would like to get my flight physical, I'm going to say, I politely have to defer. And a deferral doesn't mean you're never going to get your certificate. It means I can't tell you yes right now. The FAA is going to need more information. So they're going to get information from you. They're going to get information from your physician. They want to get a copy of your medical records. And then they're going to go over that with a fine-tooth comb to make sure that you can fly safely. And their goal is to get people flying safely. And 99% of the time, we are able to get pilots that want to fly, able to fly safely. We may put restrictions like you cannot be the pilot in command, or you cannot fly after dark, or you cannot fly when we need to use certain light signals. So there may be restrictions on what you can do, just like we have restrictions for people driving. I've a lot of pilots, the main restriction I put on is must have your glasses. So as long as we can get you seeing, hearing, and know that there probably won't be any foreseeable loss of consciousness, heart, or lung issues, most of the time we can get you certified. Now, if it does have to go to FAA, unfortunately, it does take a long process, and it can take 3 to 6 months to hear back from them and get that approval. The good news is that doesn't prevent someone who wants to fly from flying, it just prevents them from flying by themselves. So I see lots of students that all of a sudden want to fly, say, hey, I've got this history of asthma, I need to get information from my doctor, I have to get a lung function study, I have to show records of the medications I'm on. I can't issue them right away because they don't meet all the criteria, and then I have to wait. That doesn't mean they have to put their flight training on hold or their career and education on hold. It just means they can't fly by themselves. If they're in the plane with an instructor, that is completely safe and fine because there's someone else watching and able to take the controls from them should there be any issue or an emergency while in flight. So the AME's job is basically make sure you're healthy and happy, and I love to get pilots in the air and help them any way they can to make sure that they can fly and fly safely. My biggest rule of thumb is, would I get in the plane with this pilot? And if the answer is yes, then I'm going to do what I can to make sure that they meet all the criteria, and then I can certify them. Most of the time, the same day I see them, they can walk out with their certificate in hand. So it's a really fun way for me to share my love of aviation with other pilots. I always like to see pictures of airplanes. I like to show off the club plane that I get to fly. And we talk about our love of aviation. So my job's make sure they're safe, and we all have a great time and go off into the wild blue yonder.
From the wild blue yonder to the intricacies of our genes and how they affect the impact medicines have when they are administered. Dr. Debra Johnston tells us about this brave new world of pharmacogenomics.
Is the study of how our genes and medications interact with one another. And so when we think about how historically medications have been dosed, you can use a medication, or a physician will prescribe a medication to a patient based on a number of studies that have been done over several years of practice, several years of research. But what we understand about medications historically is that use a certain medication or a certain dosage of medication to treat a population or a certain disease state. Precision medicine, in which we really focus on trying to understand what the genes tell us about how our body works and how our bodies break down medications and how our bodies transport and get rid of medications.
What do genes have to do with how our body processes medications?
Sure. Our genes are generally responsible for doing something in the body, right? When any of our genes, any of us have a gene that ultimately usually produces a protein or tells our body to do something. We call that pharmacodynamics. That's how a medication affects our body. And we expect that it does something, but we also know that sometimes it has side effects. Our bodies don't want medications to be there, and so ultimately we'll take that medication and try to get rid of it, try to transform it, try to change it, break it down, get it out of the body ultimately. And so that process is called pharmacogenetics. And so the combination of the two, pharmacodynamics or pharmacogenetics, is ultimately what we understand of how medications are dosed, how they're used. Our bodies will take a gene, the gene will make a protein, the protein does something. Either it breaks down a medication or it transports a medication. And so ultimately those processes are all wrapped up in this pharmacogenomics process.
So I have heard both the term pharmacogenomics and the term pharmacogenetics, and they seem to be used interchangeably. Does it mean the same thing, or are there differences between those two concepts?
Pharmacogenomics and pharmacogenetics are oftentimes interchanged. We casually just interchange them all the time. There is a formal difference between the two. When we talk about pharmacogenetics, typically the focus is on a single gene or a single drug gene interaction. So we might think about how an enzyme or a protein breaks down a medication or transforms a medication. So we might take a pain medication, for instance, and understand how one of our genes is responsible for breaking down that medication. That single drug and single gene is really, we would call formally, pharmacogenetics. Pharmacogenomics, anytime we put the term omics on the end of a word, so we might say genomics, pharmacogenomics, proteomics, etc., that term really means that we're talking about large data sets. So we might talk about multiple genes. We might talk about a gene panel. But ultimately, it's responsible for many genes and oftentimes many different medications or many different outcomes or disease states. And typically, omics requires the use of computing, high-powered computing, in order to understand all the makeup and all the interactions between those many different parts.
So when we look at our genes and how our bodies process medication, is there usually a one-to-one correlation with one gene being responsible for one medication?
Oftentimes, no. Straightforward. There are many different genes and many different processes that are all responsible for how our bodies break down and clear and get rid of medications. So oftentimes, no, it's not just one it's not just one particular gene. It's a combination of many different things. However, the data does show us, and years of research and years of clinical practice have shown us that many times there are some medications that do have a single, more predominant gene that will affect its metabolism. And so when we look at these medications in clinical practice, and the guidelines that we have for these medications, oftentimes there will be certain direct pathways, certain genes in particular for certain medications that are most predominant and most profound. The alternative, or the other way of the opposite effect, is that we have many different genes that we know of, And so oftentimes it's not just a single gene that we have to focus on, but many different genes. And so oftentimes in clinical practice, we will run a panel of different genes and different genetic tests that will help us to understand how many different medications actually interact with our bodies.
So does it work the other way? Can my medications affect the way my genes work?
There are times in which medications can affect how our body processes work and can affect, so if we expect that our genetics tells our body to do something, there are some times where certain medications, certain interactions can come in and kind of short circuit that process. So really changing the way that we would normally expect that process to work, the way that we would expect our body to break down a medication, there are some times in which some of the medications we take can interact with that and actually change how that process works.
Can you give us an example of a medication where my genes might really affect the way that medicine works for me?
Sure, I can give you a couple. But we'll keep it brief. So we'll start with a pain medication. So we're all familiar with opioids or medications. They're strong medications that are used for pain. The opioids, especially codeine and tramadol, which I think many of us are familiar with, are medications that are again commonly used for pain. These medications in most people, about 75% of the population, or 3 in 4 individuals work just fine. We would call these people normal metabolizers. They break down or they metabolize the drug appropriately. However, there is a certain percentage of the population that will either break down the medication or change the medication, or metabolize, we would say, too fast or too slow. And when that happens, that can either lead to toxicity with the medication, so we'll have side effects. Usually that's it slows our respiratory or our breathing rate, or we can have certain cases in which the drug just won't work at all. And so either one of those conditions can work at any given time. There are literally dozens, if not hundreds, of these examples that we can point to with certain medications, but that is one that I think most people would probably be familiar with.
Thank you so much. It's been great talking to you.
Oh, thank you so much. It's a pleasure to be here.
So I know that you are a cancer researcher in a very fundamental way. How does pharmacogenomics and pharmacogenetics play into what you do?
From a perspective from research, we have kind of knowingly given patients across the spectrum the same drug, understanding that many of them will be responsive or non-responsive to those therapies. Because you and I are different in our DNA, in small ways, we can actually predict a little bit better now responses to given both chemotherapies as well as many other kind of standard therapies based on our DNA structure. From a research perspective, we are continuing to understand that. Some of them are very well known to certain chemotherapy drugs, but others are just beginning to be understood. And as we get more and more patient data, and patient data is the key thing. Okay, you had a really good response to therapy, or you had a really bad adverse reaction to a drug. Many of those things are predictable now based on what our genetic code is doing for a given drug. And so it's becoming much more practical to actually starting understanding what drugs should be given or shouldn't be given, probably more importantly, to patients based on that.
So now, is that a difference based on my own genetics, or is that a mutation in the tumor that you're dealing with?
So there's two different aspects. In tumors, we know that they respond to therapies based on their mutational code. But for pharmacogenomics, it's actually your normal DNA. We've known for a long time that cancers it's basically a mutation in that has caused that cancer to grow abnormally. It should be growing normally. But those are very different. Those are different than what we're looking at for your ability to respond to it. Your normal cells responding to a drug versus your cancer cells.
Is there a role in treating your cancer for testing the cancer's DNA?
Yes. Our ability to go through the entire cancer genome, which took the first time they did it over 10 years in about 2 hours, has been one of those things that are called accelerators that allow us to be able to really detect that. So currently we are just open a protocol that every patient with cancer or precancerous lesion will have access to having their whole genome,
Their own individual genome.
their cancer genome,
Their cancer genome.
completely looked at, and we can actually then predict response to given chemotherapy drugs based on that. But as important as your DNA, so your DNA, that's the building blocks, but it has to be photocopied. And that goes into a structure called RNA, which makes the protein, which is where the action occurs, right? And so we know that sometimes the DNA doesn't get photocopied. So we actually are looking at both the DNA and does that mutation get what's called translated into an RNA, which makes the protein. And so those things they will be standard of care, just like you getting an X-ray. They'll be standard of care within years. New therapies, like I think that when I was in practice, my first 20 years, 13 new drugs got developed. Last year, 43 got developed. And so because we have that basic understanding now, we understand much more how to treat those individual cancers.
You mentioned that the first time we sequenced the human genome, it took 10 years to do that, and now you can sequence a person's cancer, the entire genome, in 2 hours. How does that play into developing our mRNA vaccine that we all think about for COVID?
In the same way, so a virus is very similar to a cancer. It goes in, causes those genetic changes to happen within the cell. They can get that, what used to take us years to be able to detect what was going on in the cell, now can be done in hours to minutes. And so as soon as that infection occurs, we can actually sequence it and know exactly what's going on. And that helps lead to our ability to make a vaccine as quickly. I mean, I think the first vaccines took years to actually make. But to be more predictive, to make our RNA vaccines and the other adenoviral vaccines that were used to actually treat COVID. So it does apply to other things other than just cancer, our ability to really rapidly look at those building blocks that cause many of the changes that go on in a cell.
It's just incredible, the explosion in technology in our careers.
In our career,
Yeah.
How would you know that you're going to be doing a lot of genomic medicine?
Would not have guessed.
Yeah.
Would not have guessed, and I imagine you wouldn't have either.
I wouldn't have either. The fact that I'd have to know,
Yes.
much more beyond
Yes.
what the DNA is, but how important it is in our practice.
Yeah. Thank you so much for taking the time out of your schedule to sit down and talk with us and educate our viewers about DNA, pharmacogenomics, and cancer treatment.
Well, thank you. Nice to see everybody.
There is great value in knowing how our bodies differ in their sensitivity and reaction to the drugs we are given. And after a drug is prescribed, what is the process and who is the person who translates the medical language on the written prescription to the bottle of pills we take home? I had the opportunity to sit down with Dan Hansen, Dean of the South Dakota State University College of Pharmacy. Dean Hansen talked about the multiple roles a pharmacist may have and their impact on choosing the best medication for a patient. So before I was a physician in training, a medical student or a resident, I really didn't have a clue how much pharmacists did in our healthcare system, how they worked as part of our team to help patients. And here at SDSU, we have a program that are training all of our region's up-and-coming pharmacists. So tell us, what do pharmacists do in healthcare that probably the average person or patient doesn't see when they're interacting with our healthcare system?
Oftentimes, everyone recognizes their pharmacist at the corner drugstore, right? So whether you're going to a local mom and pop type of pharmacy or one of the chain pharmacies, that person or that enterprise is the most accessible healthcare practitioner really in the entire healthcare system. They're open oftentimes, early in the morning, late into the evening. Some are even open 24 hours. And that's really just one piece of pharmacy. Certainly they're there to help with filling prescriptions and answering questions, giving immunizations. But really wherever there's medicine involved, involved, there's typically a pharmacist involved as well. And so we have pharmacists in health clinics, so whether that's locally at physician clinics like here in Brookings at Avera and other places, but then also within health systems, hospitals, rounding with physicians, answering questions that nurses and providers have and things like that. And then certainly within all your specialty areas as well, all the way from infectious disease to transplant and things like that.
I can count many times when a pharmacist has saved me either extra work when they already had the expertise or really saved us from mistakes. They're really important for the quality of what we do in patient care in a lot of settings. The hospital, you're definitely probably having a pharmacist oversee a lot of things that go on with medication orders there. Yeah.
Right.
So an essential part of the team, but you're right, probably retail pharmacists are where our patients actually see them face to face the most. What would you say is the special expertise of pharmacists? What do pharmacists bring? What skills and knowledge can patients get from those people?
Yeah, so pharmacists are really designed to be the medication experts. And you think about a physician or a PA or a nurse practitioner, their expertise is in diagnostics, trying to figure out what the issue, either acute or chronic, might be. And so pharmacists, I think, can really help manage some of the chronic disease states, especially within the medications involved in treating things like diabetes or high blood pressure, if somebody's on a blood thinner, things like that. And so working in conjunction with the patient and the provider to make sure that the therapy or the medication that's being used is being used appropriately, that dosages don't need to be adjusted, that there's no potential for interactions and things like that. That's really where their expertise is when you look at the model, the healthcare model.
How can a patient better utilize the expertise of those pharmacists in day-to-day life? And so maybe that's at the retail pharmacy or elsewhere. But
yeah, I think it depends on where they tend to go. I think certainly if you're in a medical clinic where there's a pharmacist present trying to utilize that individual because they have access to your medical record and communication with your provider, but certainly in the community setting, using that individual, if you go there to fill your prescriptions and you're looking to buy an over-the-counter medication or maybe a doctor suggests a new medication, talking about possible interactions and is it safe. And then certainly now with immunizations and whether that's COVID or flu, whether it's Shingrix for shingles or travel immunizations, pharmacists and pharmacies are accessible all times of the day to be able to give those shots, and I think that's a huge public health advantage.
Yeah, it's interesting you bring up vaccines because when do you think pharmacies started being such an essential role player in vaccines? We saw them play a huge role in the rollout of our COVID vaccines this year, but they've been giving flu shots for quite a long time, but I assume that's not always been the case. When did that change?
About 20 years ago, really, here in the state of South Dakota. So when I graduated from pharmacy school, it was still pretty new in our curriculum that we trained pharmacists to do that, and now it's done right away in the first year, so our students will give thousands of immunizations by the time they graduate. I actually saw statistics just last week that pharmacists gave more flu vaccines last year than any other health profession. And so I think oftentimes we think about it in nursing and things like that, but again, just the sheer accessibility of pharmacies and pharmacists helps them be an important component of that.
Yeah, they've been crucial this year. So tell us a little bit about the graduates of our SDSU College of Pharmacy. What did most of your graduates go on to do? Where do they go? What type of pharmacy are they practicing?
Yeah, so our students tend to come back or go back to where they're from. So if you look at SDSU in general, kind of a 200, 250 mile radius around Brookings. And so our students tend to go back to those communities. I always say a net importer of students, so we have students that come from outside of South Dakota to go to SDSU and then tend to keep them here. But our students, when we graduate a class of 65 pharmacists, a little over half will actually go on to do a residency. And so additional year or two of training is needed to really go into some of those specialty areas. If you want to be a pediatric pharmacist or oncology pharmacist, somebody who works in pharmacogenomics, you're going to have to do probably 2 years of additional residency above and beyond graduation. So about 50% there. Probably another 40% or so will go into community pharmacy, and then kind of everybody else is other, whether that's a consultant pharmacy or something else within industry or something like that is really where we see our students go. And that's been a pretty dramatic shift over the last few years. I would say probably 10 years ago it was 70% community pharmacy, 30% residency and other things, and now you're seeing a pretty distinct majority going into residencies and further training.
Sure, and I'm sure there's also places in research and academia where a small number of people go, not unlike other branches of medicine.
Right, regulatory pharmacy and those
Yeah.
types of things, especially with trying to move more and more medications through the approval process and into the market and things like that.
I find as a physician, my pharmacist, we have a pharmacist in our clinic, which has been amazing, or the use of our community pharmacist helpful when we're talking about drug interactions, people who are on a lot of medications and trying to minimize that, or even, you know, small things like making changes in doses of insulin and stuff like that. So I hope this enlightens our patients to really know what our pharmacists can do for them and how they can help. So I really appreciate you educating us a little bit about that. Go Jacks.
Yeah, absolutely. Thank you.
All right, I've got our expert pharmacist here, Dean Dan Hansen of the SDSU College of Pharmacy, and I want to pick your brain on a topic that I spend a ton of time thinking about and talking about with my patients, which is over-the-counter medications. So just because some of these medications are over-the-counter does not make them 100% safe for everybody, and they definitely have the potential for harm. We see it often. So I'd like to just run through some commonly used medications. Let's talk about what they're used for, who should be cautious with them, and what kind of problems they can cause, all right? Let's go. Let's start with aspirin.
Yeah.
Tell us about aspirin.
So aspirin is an older medication.
Yeah.
I always joke that it'd be interesting to see aspirin go through the drug approval process
Right?
today, because I don't know that it would necessarily fly through. And so you think about aspirin, common pain reliever. It's used, you know, widely and often and for that purpose. But we've also seen over the years it used in cardiovascular to decrease cardiovascular risk, which there's been some recent reports on maybe we shouldn't be suggesting that at the rate in which we have been historically. And you also see some studies that show that it may decrease the chances of colon cancer. And so there's more research being done around there, whether daily exposure or daily intake or regular intake might decrease colon cancer. Biggest thing with aspirin in the general population is obviously it increases bleeding, which is why it's nice to use as a cardiovascular medication. But it also has high risk for GI upset, like ulcers and things like that. And then it should never be used in children, increased risk of Reye syndrome. So really anyone under the age of 18 shouldn't be using aspirin over the counter without approval from a physician.
Yeah, I think there was a point in time where across the board, a lot of physicians were telling all their adult patients to take a baby aspirin every day, and we're definitely rethinking of that. So worth talking to your healthcare provider about that.
And it always is a balance of risk and reward, right? You know, every medication has a risk of side effects and harmful events and things like that, but are the benefits outweigh those risks, and that's where the discussion needs to take place.
Okay, how about non-steroidal anti-inflammatories or NSAIDs? So this would be like ibuprofen, Advil, Motrin, or naproxen or Aleve. Tell us about good things and downfalls of these meds.
Pretty safe class of medications overall. I think, you know, things you have to be obviously used for things like fever, pain, inflammation, that type of stuff. As the name suggests, anti-inflammatory. So anytime there's inflammation present, it's a good medication to choose. Over the counter, doses are a little bit lower. Obviously, some of those prescriptions are available by prescription at higher doses and things like that. Same thing, GI upset, chances of ulcers and things like that. Also, you have to be careful from a long-term aspect. You know, using those medications not only increases the chance of ulcers, but if you use them for headaches and then use it regularly for say 7 to 10 days and then bounce off, you can get rebound headaches and things like that as well. And so just watching how long you use it, how often you use it, and making sure that you know, if it's a long-term use, again, you're following up with a provider or physician to talk about other options.
Yeah, I also caution my patients with kidney disease or cardiovascular disease that some of those patients probably should stay away from these types of meds. How about acetaminophen or Tylenol? Different class.
Yeah, that's a big one. You know, Tylenol's great for pain, for fever. You know, like ibuprofen and the NSAIDs that we talked about, commonly used in children and infants. And so I'd also talk about dosing and making sure you're getting proper dosing and some of those types of things. But the other thing with Tylenol that you have to worry about, one is overall dosage and making sure that you're not taking too much Tylenol. Tylenol tends to be in a lot of other products, whether that's cough and cold products or things like that, and so making sure that you're not getting an overdose of Tylenol. And the biggest side effects with Tylenol is probably liver toxicity, which again is why it's important to make sure that if you look at over-the-counter recommendations, 3 grams or less when you look at your total daily dosage. But really, you know, overall, again, I would say a relatively safe medication if used properly.
Yeah, as long as you're not overdosing, really safe.
And don't take with alcohol.
Yeah. Let's hit one more. I think we've got time. My personal least favorite, maybe over-the-counter medicine, diphenhydramine or Benadryl. Tell us about that.
So Benadryl.
Why as someone who takes care of older people, hate diphenhydramine?
So Beer's criteria, right? So Benadryl is a very effective antihistamine. It's an old antihistamine, so class 1 antihistamine, which means that it's prone to cause drowsiness, dizziness, and also cause urinary problems. And so when you think about elderly population, dizziness can lead to increase of falls, and certainly there's often issues with urinary issues, and so it can make those worse. I think if someone's looking for an antihistamine, it's nice if it's maybe an allergic reaction or bug bites and looking to help sleep and prevent itching and stuff at night, but in the right population. In children, it can actually cause the opposite of drowsiness and cause some hyperactivity and things like that, so it's always good to monitor that. But in general, I would say class 2 antihistamines tend to be a better choice, things like loratadine or Claritin and things like that. Yeah, just lots of side effects with diphenhydramine. You find it in a lot of sleep products, which I think patients take these over-the-counter sleep products and they can have lots of side effects. So and anti-nausea, motion sickness medications and things too.
Good. Well, thank you, Dan, for helping us learn a little bit more about these commonly used medications. We appreciate that, and we appreciate our pharmacists.
Yeah.
Another great reason to talk to your pharmacist before you're buying over-the-counter medications.
Yeah, drug interactions.
The medical community is composed of many people with many jobs, all of whom have as a goal to make you healthy when you are sick and keep you well in your life. We'll be back after this. Thank all of you for inviting us into your homes and giving us the opportunity tonight to explore some stories of personal interest to our Prairie Docs. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
The nature of medicine tends to showcase the science and technology of treatment. The truth is that healthcare is about a relationship. Humanity in medicine. Next time, On Call with the Prairie Doc, celebrating our 20th season.
Prairie Doc programs have provided truthful, tested, and timely medical information for 20 seasons. Hello, I'm Dr. Jennifer May of Rapid City, and I serve as a board member for the Healing Words Foundation. Please join us as we celebrate this milestone, offering healthcare information in our state and across the region. Rick and Joni Holm began this mission years ago. And every week since then, our Prairie Docs and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free and easy access to the entire Prairie Doc library. I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions,
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings Madison Flandreau District Medical Society,
Pierre District Medical Society,
Yankton District Medical Society,
Orthopedic Institute, Lake Poncet Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communications.